This Guy's Garage. Like and subscribe.
We have a new sheriff in town today. Anyway, that's the way things roll. Pursuant to Standing Order 1082 and the motion adopted on November 8th, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. And I would like to welcome our panel of witnesses. Ms. Lovegrove.
I am also an activist and member of the Harm Reduction Nurses Association, and I am absolutely infuriated by the Federal Ministry of Health's decision to support and enable BC's political move to walk back decriminalization.
Ms. Eugenia Oviedo-Yucas, professor at University of British Columbia. So with that, Ms. Yucas, you have the floor.
I am a Latina woman. I am today speaking from the beautiful and ceded territory for the Squamish people of the water. I am a professor at the School of Population and Public Health. I am a Canada Research Chair in Person-Centered Care in Addictions. And following up the statement from Sarah Logroff, and as a continuation of what she was bringing up, one of the key things for continuing this statement is the overdose crisis emphasizes that we need diverse strategies and action in cooperation is key.
Next on the docket, we have Martin Paget. Monsieur Paget, vous avez la parole pour 5.
I am a father of 2 young children. I'm also a person with experience in the field and with academic knowledge who's been working in harm reduction for nearly 30 years. I've been a street worker in Montreal and Toronto and worked at the heart of numerous crises such as HIV, AIDS, hepatitis C, housing, COVID-19, and the current overdose crisis we've been experiencing for the past 10 years.
I have Ms. Strico.
I'm here today to address the profound failure of British Columbia's illicit drug decriminalization pilot and its dangerously labeled Safe Supply program.
We'll start a round of questioning now. Ms. Goodridge, you have the floor for 6 minutes.
Thank you, Mr. Chair, and I want to thank all the witnesses for being here today and providing their testimony. Professor Oviedo-Yucas, I understand that you were involved with both the Naomi and Salome studies, which are used as the evidence that brought forward the Safe Supply programs. And my understanding is that both of those studies used witness dosing. Is that correct?
Yes, that's correct.
So, based on that, a study that used witness dosing, how can it be used as evidence to support giving take-home pills of 30 to 40 dilaudid hydromorphone pills a day?
Well, first of all, the study, as you said, was injectable, and we do hope that people that are ready for it can take the doses with them in the cases that are indicated by, the prescriber in a conversation with the physician. There was always the intention that as clients evolve, the treatment will evolve with them. We did have...
Did the study look at that evolution?
No, we didn't. We had a trial, and the trial ended, and we did show that for our participants, injectable was more effective than oral.
No, I appreciate that. So does the diversion and the reports of diversion that are happening of the take-home hydromorphone and dilaudid pills, does that concern you?
First, the diversion that is shown is so minimal that for the scientific perspective is expected for the number of people that in a big scope, there is a very small percentage of people that are struggling with opioid use disorder that are getting the dilaudid pills. So the possibly expect the number of people that might be sharing or selling the medications, because that's not the medication for them, because we have few options, as I said at the beginning.
So just to
it's
clarify,
a number that is expected.
Just to clarify, so the amount of diversion that's happening provides no concern to you whatsoever?
It's expected.
Okay, I appreciate that. Alors, je vais demander...
I would like to address my next question to Mr. Paget. Of the 49 districts in Montreal that were assessed by the Montreal Police Force in 2021, Hochelaga Maisonneuve, the district where dopamine's located, is ranked 4th for crime levels with 57.7 crimes per 1,000 inhabitants. Given the numerous playgrounds, schools, and the Edmond Hamelin Park that's just on the other side of the street. What measures have you put in place to make sure that drug injection sites where you have crack, heroin, would not worsen the already very disastrous criminal situation in the district? These supervised injection sites at dopamine are contributing positively to eliminate consumption in public areas. So these injection sites make sense and contribute positively in a community where well before the presence of our organization, there was a very precarious social crisis, not just in connection with drugs, but just in connection with the long-standing poverty in this area. So the presence of dopamine had been helpful. People come and use our services that are supervised rather than consume in public spaces that are unsupervised. There has not been an increase. There has even been a drop. In terms of, syringes found in public spaces, there's no increase. There's a drop, in fact, in consumption. I have very little time. Thank you. I have seen in the news that parents have concerns about their children being very close to the dopamine center. What are you telling parents whose children play nearby? I don't know if you have much information about our organization. We don't have a school next door. Dopamine has always played a very positive role in terms of communicating with the community because we're rooted in the community. We emanate from the community, including the schools. There's never been a single incident, not one.
Sturco, one of the things that you said that really kind of hit me was you said that it was effectively a Band-Aid to a gaping wound. What have you seen as in your role in British Columbia, both as an elected official as well as a former law enforcement, when it comes to diversion? Does diversion scare you?
Yeah, I have a lot of
Ms. Sturco, if I might interrupt, you have about 5 seconds to answer that question. You may have to come back to it.
Sure. Then I will just say in 5 seconds that yes, diversion is a concern. It's something that I've heard a lot about, and I look forward to speaking more about it when I have longer than 5 seconds.
So tell us, what does flexible look like for all of the agencies and levels of government that are involved?
Well, so when we discuss and do work with the prescribers and they want to do person-centered care, they do know that certain clients require an opioid medication that they cannot prescribe because it's not it's not indicated for opioid use. So not all, you see, in downtown Vancouver, you are going to be in advocacy group and you are going to be able to prescribe off-label. But in other places, you don't have that support. You're alone. So you can prescribe only a few things. You don't have prescribers. So the idea is to have the flexibility that we can have all these medications that we know are evidence-based available. So when you have a client coming to you, you can have a conversation with them and say, don't leave. I have something for you. This is the medication that is going to be the best fit for you. Maybe that person is not ready to take home. but work with them. Maybe that person is ready for somebody going with them or a family member helping. There are so many ways to work with people that are not either supervised or just let them on their own.
We have to take action. And I wanted to start off by asking Ms. Oviedo Yulques and Ms. Lovegrove the following questions. What should the federal government be doing more? Should it be declaring a national health emergency as we see numbers climb in Alberta and Saskatchewan? Should it be putting into place funding for safe consumption sites so that we can bring the death toll down, particularly on the prairies, which is staggeringly high and increasing daily? And both of you mentioned, Ms. Oviedo Yulques, you talked about dissent with the truth. How much harm are people doing, politicians doing, when they say things that are simply not true when it comes to dealing with this public health care emergency?
I will allow Sarah to speak since first.
Thank you. I thank you for the question. It's my full wholehearted belief that we need to be doing absolutely all of those things to curb this crisis. The federal government also has the opportunity to regulate the drug supply and offer a legal supply of drugs to the entire country to curb the deaths that are a result of the unregulated toxic supply. So we need to be declaring a national emergency. We need to be instituting overdose prevention sites in every single community across the country, investing in harm reduction, and absolutely offering a regulated, safe supply to everyone in this country.
Ms. Lovegrove, on my second question, the issue of being truth tellers, how much harm for those who are falsifying, providing false testimony or false information, how much harm are they doing?
They're doing irreparable harm to this country, to the people who use drugs in this country. People are dying as a result of stigma, and people aren't accessing services as a result of stigma. And when politicians utilize this as an opportunity to get election votes or get ahead in their careers, they are doing harm that is killing people. And they need to be rooting what their decisions and what they say in public with evidence and utilizing the expertise of people like the witnesses here today, rather than listening to the opinions and prohibition-era stigma that is feeding the opinions of folks across this country and only further inflaming the stigmatizing belief system around substances.
With that, Dr. Kitchen, you have the floor for 5 minutes.
Thank you, Mr. Chair, and I appreciate, and thank you to all the witnesses that are here today. It's greatly appreciated. I'll start with Mr. Paget, and I apologize, je parle un petit peu, mais...
Do speak a little bit of French, but I speak the language very slowly.
And I actually found it quite interesting that your organization is called Dopamine. And I find that interesting because, 80% of the catecholamine content of the brain is basically what dopamine is. And it deals with pleasures, satisfactions, motivation. It also deals with concentration and movement. And so I found it interesting to how you use that as the name for your organization. But you also mentioned about naloxone and talked about it and the impression I got from that conversation was that it wasn't readily available or to a great extent in your area. And over the years and in my discussions with paramedics, et cetera, that has been a big concern for paramedics actually being able to utilize naloxone. And the concerns that in some cases where they are utilizing naloxone and then have to step back because of the fear the moment they give that naloxone to that patient, when it brings that person out of the state that they're in, they often come out in a violent manner. So I'm just wondering if you would mind commenting on the aspects of naloxone.
Yes. And I hope I've understood your question properly. When I mentioned naloxone and the importance that it be accessible and that it could easily positively contribute in communities, it's because in some place naloxone is more difficult to access, unfortunately. But naloxone is an effective antidote to deal with overdose. As to fears of first responders, oftentimes it's not a violent reaction that the user suffers. It's, it's the bodily reaction to the withdrawal. So sometimes those who do get the naloxone are, relieved that they're still alive. So you have to keep the right balance in the discussion. Naloxone saves lives. It's the antidote effect that the person getting the naloxone feels the symptoms of withdrawal. But I've never heard any anecdote where they have come out of their overdose in any violent way. Of course, you need to have the right techniques, not just to administer the naloxone, but also work with people who are drug users. Thank you.
Mr. Sturckow, and thank you very much for coming, and appreciate you being here in person. And you touched a little bit on treatment and rehabilitation. And I think when we deal with Canadians and Canadians that are watching this debate that we're having here, and a lot of them are concerned about that. I mean, where are the steps that are being taken to rehabilitate and to and that prioritization of that recovery, I think, is a very important thing. And when we look at the fact that 23,800, more than 23,800, basically people due to drug addiction are having hypoxic brain injuries, and the huge impact that that's going to have on provinces, on how do you deal with those individuals and caring for them. I'm wondering if you would mind commenting on that.
Yeah, thank you for the question. So, what we're seeing in British Columbia is certainly a large number of people that have acquired brain injury as a result of overdose. I myself have administered naloxone to people in the course of my duty. I'm a former RCMP officer. And I can say, one of the things that, really worried me is that, at times there was, I'd get dispatched to a call for a person who was unconscious and suspected overdose, no ambulance ready in BC. And what ended up happening is it would take me 5 or 6 minutes to get there. And that person all that time either has very shallow and not very much breathing or not breathing at all. And then of course,
Ms. Sturckow,
naloxone.
I'm sorry, I have to interrupt you again. The member's time's up. I apologize for that, but you can get back to it, I'm sure.
Mrs. Sturckow, in your remarks, you were saying that indicators haven't been met. I'm PS to the Minister of Mental Health and Addictions. Health Canada is monitoring the BC's indicators and is telling us they are met. Could you please tell us what are your sources?
So what I'm referring to, ma'am, is what was promised by the minister, and then what was delivered. And I can share with you a little bit about what was actually promised by the minister. At the time, it was we would be getting baseline indicators, that we would have a robust set of indicators on health and public safety. The minister, who was Carolyn Bennett at the time, in May of 2022, said that we would be able to ascertain not only how many lives are saved, how many emergency department visits, how many hospitalizations, and from what we were hearing at the time from urban mayors about petty crime, And she said, all the things that we know are indicators of whether we're really stemming the tide of this crisis. Okay, so I just want to go then 8 months later, there was another press conference in British Columbia, and that was at the outset of the project, the pilot. And at that time, Minister Bennett said, I would say that we need at least, and these are quotes, by the way, sorry, I would say that we need at least 3 months to be able to get this sorted out. Also, I think as we let people know what the indicators that have been chosen, so 8 months later, they didn't have the indicators chosen, it seems. If people have ideas or they have other indicators that they would like, whether it's a small business or whether people are saying, you know, what would be other things that we could be measuring that would help determine the efficacy? So one of the things that was in the letter of requirements, ma'am, was that the amount of treatment and health care would be scaled up. There was a study that was released for the community, or the Journal of Community Safety and Wellness, and it had stated in that just prior to decriminalization coming into effect, that 64% of the communities served by the RCMP in BC did not have any access to any drug rehabilitation or treatment. So that means the majority of British Columbian cities did not have any access to these services. And while that is not the only service that should be provided, it was one of the requirements to scale up these to make sure that we were ready for as stigma would be driven down and that people could be connected to services, that they would exist. And unfortunately, they just haven't existed.
Okay, but all these indicators are posted, and Health Canada confirmed they are meeting the letter of requirements.
Well, ma'am, the other part of it too is that in the beginning, Minister Bennett had promised citizens of British Columbia that we would have a dashboard that was going to be updated monthly, that dashboard would be publicly facing, it'd be monitored in real time. Then the context of sort of the data collection was then altered, and that was then allowed to become a selective snapshot. And I can tell you very concerningly, actually, one of the pages of the snapshot up to 2024 April, that's the most recent one. What is provided there is the number of sort of treatment beds and individual clients that are served. Unfortunately, the snapshot is from the fiscal year 2022-23. So it only actually encaptures 59 days of decriminalization. And so, for us to be able to actually say at this point that they've captured data that would suggest that they could understand fully that people have accessed more treatment. There's no indicators on whether or not that was successful, whether or not people actually stayed in those services, and it's very concerning.
I have some quotes coming from you in October 2023. You were saying that this government has introduced a safe supply where they're giving hydromorphone. They give it to individuals to help get them off illicit drugs, and that we need to continue exploring. You also said this government was said to be exploring options for pharmaceutical alternatives to illicit drugs, and that's what they should be doing. We absolutely support harm reduction. I would like to know if you still stand by these quotes.
I think that what's important to note is that the concerns that I've raised over the last, I'd say, duration of my time as a member of the Legislative Assembly is a lack of evidence of the efficacy of the program, but certainly the absolute failure to look at things that are potential harms on the community. So while it's important that we continue the research and finding ways to treat people and to ensure that they can be protected from overdose through things like pharmaceutical alternatives under supervision and witnessed programs, very little data, if any at all, in British Columbia has been actually collected on things like the diversion of safe supply, which is of extreme concern to me.
Ms. Turco, I have to interrupt you again. I apologize. I'm like the interrupting cow joke that you've probably heard from your kids. Mr. Julian, you now have the floor for 2.5 minutes.
Thank you, Mr. Chair. Ms. Turco, welcome. As British Columbians, we have a responsibility. I think we would agree. We have to get a handle on this toxic drug crisis. And I appreciate you being here today. I'd like you to tell us what the death rate for toxic drugs in British Columbia was in March 2023 and what it was 1 year later in March 2024, according to the BC Coroner Service.
I don't have
Okay, I'll tell you, it was 46.2 in 2023. It was 40.3 in 2024. And that difference means the savings of hundreds and hundreds of lives in British Columbia. Now, as Ms. Briere asked you, you have been on record, and I know in conversations with you before, you've said that things like, we are not backtracking on the need for harm reduction. With our whole hearts, we want to save people. We support decriminalization and harm reduction. You weren't clear in your answer to Ms. Briere. Have you changed your position on decriminalization? And given these figures, why would you not be supportive, though we need to tweak and improve the program, why would you not be supportive when lives are being saved?
So first of all, yes, I have changed my opinion of decriminalization. And I want to be clear, too, that, it is important to note that there have been, even in previous years or months where we saw decreases in overdose deaths, even several months in a row, only to be followed then by increases. And, this is certainly the case. I actually, this was something, I've heard people on this committee speaking about before, and so I can tell you that in multiple years we have seen trends like this before, only then to spike up in other months, and then to be followed by, again, year after year, the worst records for overdose deaths that we see.
I'm sorry, it is my time, it's very short. I wanted to ask you about Moms Stop the Harm. Have you met with them?
No, I have not.
Okay. Yeah, these are families, victims of the toxic drug crisis. They have been very strong on having a range of services, including harm reduction, decriminalization, safe supply. Why would you not meet with them to hear those families out and understand the importance of having a variety of tools to lower the death rate, which I think is something
I'm sorry, Mr. Julian. You're well past time. I apologize for that, but I ask all members to watch their time closely. And Ms. Sturco, hopefully you'll have time to answer that at some other point. Of course, you could submit in writing to the committee.
Thank you, Mr. Chair. And Ms. Sturco, you're going to stay on the hot seat for a little bit longer. When you haven't had an opportunity to explain your concerns around diversion due to some of the time constraints. As someone that lives in the Lower Mainland, represents a Lower Mainland riding, and former law enforcement officer, how concerning is diversion to you, and what have you seen on the ground in British Columbia?
Yeah, so I guess my concern with the diversion of safe supply is twofold. The first one, and probably the one that's hit me the hardest, really, is the impact that it's had on young people. I've met with physicians, but I've also met with the parents of young kids who succumb to overdose. One of the first dads that I met with, his name is Dave. His daughter died of a fentanyl overdose. And at the time of her death, she had several bottles of safe supply hydromorphone in her bedroom that were not prescribed to her. And in talking to him, he said his daughter had started with cannabis and then moved on to experimentation with other drugs. And that was alarming to me. I think that given the fact that there hasn't been any study really in British Columbia about what impacts the diversion of hydromorphone is having on the overdose crisis, I think it's something that needs more attention. The second concern that I have is that we are seeing now in British Columbia that diverted hydromorphone is being discovered by police in their drug investigations, and police have even testified, I think, to this committee that there is a nexus between some of these investigations and organized crime.
So you're effectively saying that police in British Columbia are figuring out that government safe supply, or so-called safe supply, is fueling organized crime and gangs? Yes. So police have, put out news releases, have reported in the media about drug investigations that have nexus to organized crime. Gang activity in British Columbia is obviously a concern, and so any kind of
diversion or government program that would in any way put money into the hands of organized criminals and gangs is a top concern. That doesn't mean that we have to stop helping people, but when there are ways that we can mitigate risks and in fact help stem the flow of drugs into the hands of criminals, we absolutely have to do that.
One other piece that I find really interesting is in British Columbia, the overdose rates for kids in British Columbia is steadily increasing. And the children's minister actually stated that she thought that the Minister of Mental Health and Addiction here federally was doing a great job and had faith in this policy and the direction. And so I'm just curious, when you hear of things, we know that opiates are highly addictive. We've had many doctors come present to our committee on this. What is the impact on the families that children started out on this so-called safe supply that they believe is safe because it's been marketed as safe?
Yeah, so one of the most, I think, impactful and devastating stories that I heard firsthand from a father named Greg. His young daughter started using drugs at age 14. She died at age 15. And what the widespread impact was is that actually her group of friends was using drugs together. One of the kids in the friend group is still living. And she said that they did start off by getting dillies, which is the street name for Dilaudid, for hydromorphone. And they did think it was safe. They started to become sick when they started off by taking it once in a while, started feeling, the need to take it more. And then it came to the point where if they would stop taking it, they would feel sick. And then when the withdrawals were no longer being managed even just by taking the dillies, the one girl who actually survived started taking fentanyl. And even though she had access then to OAT, she still continues to use drugs now. I know her mother very well, and it is an absolutely awful journey that they're on. There's not enough supports and services, but this is widespread. And especially when we're talking about kids or even young adults or adults, it's affecting their friend groups. And I think one of the biggest things that's really concerning to me, and if I can just read this into the record, this is actually just right from the Dilaudid. So this is from Purdue Pharma. This is their patient medication information. And it says, never give your Dilaudid to anyone. They could die from taking it. If a person has not been prescribed Dilaudid, even taking one dose can cause a fatal overdose. This is especially true for children. It also says, even if you take Dilaudid as prescribed, you're at risk of an opioid addiction, abuse and misuse. This can lead to overdose and death. To understand your risk of opioid addiction, abuse and misuse, speak to your prescriber. So, my concern is the lack of
Ms. Turco,
research.
I'm sorry, I'll have to interrupt you there. I think that's a good place to stop.
So we've heard both sides on the issue of safe supply. We've certainly heard people say that there's plenty of evidence for the beneficial effects of safe supply, and by that they meant the Canadian version of safe supply, which is getting a whole bunch of Dilaudid and going home with them. We've also heard the opposite from members of Health Canada, who generally seem to be supportive of the idea. However, they admitted there wasn't a lot of evidence for a safe supply in the Canadian context. We also heard the same thing from the Stanford Lancet study, where they were very much against safe supply. And I would note that the BC health officer in his review, or her review of safer supply, also said there wasn't a lot of good evidence for safe supply. Now, what there is a lot of good evidence for is IOT, intravenous opioid agonist treatment. Naomi and Salome, as Ms. Goodrich pointed out, were directly observed treatment. A lot of the evidence from Switzerland and the studies, which are again cited as evidence for safe supply, those too were observed treatment with injectable drugs, heroin at the time. So given this, and given the concerns about diversion, which I think are totally legitimate, and that's why the Swiss have this approach, because of the concerns of diversion. Given both this, and given the fact that a lot of people in BC continue to die because of fentanyl, that's what's killing them. And even though they get Dilaudid, it's not enough for them. They use fentanyl. What do you think about intravenous observed treatment in this kind of Swiss model that people can come into a treatment facility and get observed injectable doses of fentanyl. Would you be in favor of that, or at least willing to contemplate this?
Actually, something that I wrote a letter to Minister Yara Sachs, and I also carbon copied that to Premier David Eby, that I actually was supporting a call from doctors across Canada, addiction specialists, including 72 in British Columbia, who were calling for witnessed prescribed alternatives that are recovery oriented. And of course, my purpose in coming here today isn't to stop people from getting life-saving medications if this is what is important. What I want to make sure is that we understand the scope of the risk to the population. And there is a population level risk even identified by Dr. Henry, for example, in her report that you referred to that was released on February 1st. So, if we go and we're going to be providing treatments, which as you stated in Dr. Henry's report, has not enough evidence at this point to be described as fully evidence-based. We need to make sure that we're not causing unintentional harms.
No, I've heard from addiction specialists who are in favor of IOTE that our safe supply was kind of a poor man's version, because IOTE, when you bring people in and you witness them getting injections, is a lot more costly. That is obviously an issue for governments. Do you think we should be putting more money into providing more of that kind of therapy versus the present kind of safe supply?
It's a pay now or pay later scenario.
It's a what?
It's like pay now or pay later. And what is the cost of a life? When we reduce these things to what will it cost, and we look at the human cost, 6 people a day in British Columbia losing their lives. And I think that if there are alternatives that can protect the public from diversion, make sure that we're ramping up things like prevention strategies and actually warning people that it is not safe to take other people's medication, and actually safeguarding the public. Of course, we need to invest in a whole scope of services, but also in social supports, housing, things to help people become stable so that if they do access medical programs, that they have the social stability to maintain their use of those programs.
Maybe I can ask this same question to Professor Ovidio Ducas. Should there be more facilities that would allow directly observed treatment, including potentially intravenous and or smoking drugs as an alternative to the present safe supply with pills that you go home with?
Definitely an alternative, and not just maybe open new facilities, but integrated on the services that you already have there. Open new facilities can be costly. If you integrate it on the services, you make it mainstream, and then people that leave a treatment can go to another if they are ready to switch from injectable to oral medications. That answers your question?
Yep, thank you.
With that, Ms. Goodridge, you have the floor for 5 minutes.
So after 9 years of this NDP Liberal government, we have tragically seen over 42,000 overdose deaths, rising child overdose deaths and rates. Do you think that the Trudeau government is doing a good job at managing this crisis, Ms. Sturco?
No, I don't think the governments at either level are doing, both provincially and federally. I think that not enough emphasis has been put on prevention, certainly. And, we keep having these discussions about individual services, which, while important, what we really need to do is start developing a true framework for both the country and for individual provinces that is a recovery-oriented system of care that has strength in all 4 pillars. Not the one-legged stool of simply trying to, look at one service option at a time, but vastly scaling up all parts of the pillar, including enforcement. One of my greatest concerns, honestly, is the lack of prevention that we have and education. And I'm especially troubled to see young kids and families, and especially having to meet with families of people who've lost a child. And I really want to be strong in my statement here, I guess, today is, this isn't about stopping people from getting help. but this is about making sure that when people reach out for help, that first of all, it's there. And that in any treatment options and pharmaceutical options that go forward, we have to make sure that we're not increasing the risk to other people.
Actually, that's a great segue to my next question. What is the approximate delay, or how readily accessible is detox in your riding or BC more generally? And what is the wait time for government-funded treatment in your province? Approximate.
Well, unfortunately, and I do have some notes on it, it's actually incomplete data. So here we are talking about a government almost a decade in power. In our province, we have been in a public health emergency for 8 years. And I heard the comments today about should Canada declare a public health emergency, and I want to be clear that it does not help you to declare a public health emergency unless you treat it like an emergency. And so in our province, to have declared a public health emergency and then have no data on wait times for treatment, to have so many communities without access to services, even scaling up things like access to OAT, where, we just saw when the province came and asked Prime Minister Trudeau for, to roll back on his decriminalization parameters.
I was proud. They finally decided to copy something Alberta was doing and roll out the virtual opioid dependency program.
And so, but why? Why would it take that long? My question really is that, so here we were 8 years, into an emergency, and only at the 11th hour of a failed experiment, introducing something that could have provided access to a variety of medications and treatments to people across the provinces, particularly in locations where they don't have bricks and mortar services. It's disturbing.
So just today I got a message, and I often get messages from moms that are having a hard time because their children are addicted to drugs. And I got a message from this one mom, and she said, "I'm so sorry it's been so long. I've been in survival mode, fighting to save my daughter. Her 13-year-old friend just died yesterday here in rural British Columbia from overdose at the local hospital after the local hospital released her from an overdose on Friday. Please help us. I can't bear going through another child's funeral. These children deserve so much more than this ignorant system. Doctors should have held her under the Mental Health Act until she could have gone to detox. Another family ruined, many who loved her traumatized, and more deaths to follow if something doesn't change." That message, as a mom, as someone that sits there, the fact that 13-year-old beautiful child couldn't get into detox and was released after having an overdose at 13 speaks to how broken this system is. I guess my question to you, Mr. Sturco, is, have you seen any increase to detox capacity in the last 2.5 years or 5 years?
I'm sorry, Mr. Sturco, very, very briefly.
Not notable, only incrementally marginal. And in fact, when it comes to youth, we know that the only complex mental health and addictions treatment center that was located in Vancouver is actually closing.
Thank you very much, Ms. Sturco. Now we'll turn to Ms. Sido. You have the floor for 5 minutes, please.
Thank you, Mr. Chair. Mr. Chair, before I proceed to my question to the witnesses, and thank you, witnesses, for your testimony. Mr. Chair, I have one matter I want to address. Hopefully, it won't take much time, Mr. Chair, given the comments of Pierre Poilievre last week, where he suggested he would use the notwithstanding clause if given the chance, and the petition tabled by Arnold Wierson on Tuesday to restrict abortion access in Canada, and the anti-choice March for Life in front of Parliament Hill today. I feel it is relevant to move the following motion that I had given verbal notice on February 15th.
Ms. Sido, excuse me, there is a point of order.
It is my time.
Ms. Sido, there is a point of order.
Mr. Chair, it's my time.
There's a point of order, Ms. Sido. Ms. Goodridge, you had a point of order?
I was just curious where she was going with this, but she's made it clear that she's talking about the motion that she had on notice.
Very good, thank you. Please continue, Ms. Sido.
I move that the Standing Committee on Health affirms it is support for reproductive and sexual health rights across Canada, recognize that the right to safe and legal reproductive and sexual care in the right to health care, condemns any effort to limit or remove sexual and reproductive rights from Canadians, and emphasize the importance of protecting and expanding access to reproductive and sexual health care, including abortion and contraceptives. I hope this motion is in order, Mr. Chair, and I hope it is not going to take much time to discuss this before I proceed with my question to witnesses.
One of the biggest challenges when it comes to having these broad sort of studies, we can't actually find these solutions. And so I wasn't trying to play any politics when I moved
Appel au
forward.
règlement.
Point of order. Is being spoken, what relation does it has with the motion?
Committees know that certainly we allow a lot of latitude for people who wish to speak in committee, and I think that has been. I understand that you've not been at our committee previously, but in the spirit of Mr. Casey, who unfortunately is not here, that is the spirit in which we have operated previously, to allow members significant latitude, and certainly those committee members who have been here previously would recognize that. And I realize that I don't sit in this chair all the time, but I will continue to operate in the same spirit that Mr. Casey has for the last 2.5 years. So with that, I will return the floor to you, Ms. Goodridge.
Thank you, Mr. Chair. And I think it is actually extremely relevant to be talking about breast cancer screening, because the breasts are, in fact, a sexual organ, and they have a major role that they play in women's health and women's health rights. And so this motion that was deposited it is exactly on this space. And I think this is part of the overall issue, is we should be having conversations here in this committee about the tragic overdose crisis that is griping our nation, and the fact that in 9 years of this NDP Liberal government, we've had more than 42,000 people.
Yes, Mr. Julian.
Thank you, Mr. Chair. There is an issue of relevance. The motion is reproductive and sexual health rights. This shouldn't even be
thank you very much, Mr. Julian. I think that I've already spoken about that with respect to relevance.
There is an issue
with respect to relevance. Mr. Julian, please, while I'm speaking,
I'm going to challenge you, Mr. Chair, on your ruling.
If Mr. Julian, please
speak.
Mr. Julian,
I challenge
you.
your
If you want to
decision.
continue to be okay.
Point of order. Point of order. 1 minute, please, Madame Lelouch.
I will have to do no choice but to adjourn the meeting. So, Mr. Julian, I will be very clear. I have already ruled that this is how this committee is operated. You too, sir, have not been here. So shame on you for attempting to do this.
I challenge your ruling.
Meeting adjourned.